Hi, everybody. I am going to finish up my lecture on cardiac surgery. Forgive me, I'm in my spare room today instead of my kitchen. We have lots of people working from home, so forgive me. But I will finish this up really quickly because there's not really a lot left. So I will share my screen and show you guys pediatric procedures. So hopefully, as you saw, not a lot of cases left. And they're all very similar. So I'm actually not going to spend any time going over the procedures. I'm kind of just going to tell you what to focus on and what to study because I've included YouTube links as I have been since we've started distance education so that you can watch these videos of these surgeries. And of course, you all have a Jomi account now. So it's not only the videos that I'm posting for you, it's everything that's on Jomi. And I know you have an account. So I don't usually link to Jomi very often. I usually do the YouTube videos so that you use all of the resources that you have available to study this stuff. Because I know it's harder with distance education because we're not there talking about it and having a discussion together, but there's not a lot left. So let me go ahead and get through it. So I'm going to start on page 1069, actually, not 70, because it starts a little bit at the bottom of that page. So it separated pediatric procedures for you. This is kind of perfect because we are going to flow right into special populations for our next chapter. So this should prepare you a little bit for pediatric procedures. So before I get into the first surgery, I want to just do an introduction. I should stay on the first page. So looking at your introduction on page 1069, so congenital abnormalities is what we're typically going to be treating with these pediatric patients. So congenital abnormalities must be treated as soon as possible. So you will see a lot of neonate, very young, and infant patients. So additionally, all aspects of the surgical procedure are dealt with on a smaller scale. So everything is so much smaller. So definitely watch some videos so you can see the huge difference in those instruments. They are much smaller, and you'll see some of the instruments we use on adults you're not going to need for children. Okay, so look at preoperative preparation, same page. This is telling you that your pediatric cardiac instruments are going to be smaller and more delicate. So you already knew that. What I want to point out to you as the script tech, that means you need to be more delicate when sending the instruments to SPD. As you should already know, we put the delicate instruments on top. So you wouldn't want to throw that sternal saw on top of all these delicate instruments, would you? That could ruin them. So make sure you are treating these delicate instruments as they should be. And watching out for that. That brings me to what I was talking about. Some of the instruments you may not need. So it says at the bottom of that first paragraph that a sternal saw is not usually necessary for infants. The sternum is typically cut with Mayo scissors. So that means it's so small and thin that it's able to be cut with scissors instead of a saw. So pretty interesting, but you got to watch the age on that. So as they get into the adolescent age, I would have that sternal saw available. Of course, you're going to have lots of patches and grafts for these cases. And again, they're very similar to the adult cases. So I'm not going to really go through the procedures, just kind of go over some things for you to study and give you this slideshow that you have all the links to the videos. Okay, let's start with atrial septal defect. So I've got some pictures on here so you can see where the defect is and what's actually happening with the blood because of that defect. So we know the blood flow of the heart. So this is throwing off the normal oxygenated and deoxygenated separation of the blood. So unfortunately, you're going to end up with mixing of the oxygenated and deoxygenated blood on this one. So let's look in your book. So it starts with, it starts with the pathology. So repair of ASD, atrial septal defect. So this is an abnormal opening in the wall between these two atrias, as you see in the picture. So the opening is at the top of the heart. Now there's 3 different kinds, which is on my next slideshow, and you need to be aware of all of those. For the moment, I'm going to skip over to the second section of the same page. So I'm still on 1070. So this defect, the atrial septal defect, results in shunting of oxygenated blood from the left atrium across the defect into the right atrium. So that's what you can see right here in this picture, and that's why unfortunately we are having a mix of the oxygenated and deoxygenated blood, which of course is not a good thing because we need oxygenated blood to go through that aorta to the rest of the body for our tissues. Our muscles need that oxygen. Same page, right side of the page toward the bottom. A child who's asymptomatic for this defect should undergo surgical repair around the age of 4 or 5. So what I need you to do is read through basically the difference of what they do when the patient is symptomatic versus asymptomatic. And then lastly, you'll see that they're going to use a Dacron patch or graft to fix this one. So that's why I reminded you of that at the top, but you can watch this surgery so that you can understand it. And there are the 3 different kinds of defects that you need to be familiar with. So I won't go over the details because you guys can read. So make sure you know that there are 3 different kinds and just be familiar with that. You don't need to focus on the details about it. Just know what they are and that there's 3 different kinds. Okay, that brings me to ventricular septal defects. So what I want to point out is, first of all, these 2 are very similar surgeries, right? So if you're looking at post-op complications, right before I get to this one, 1071, the very bottom, post-op complications, these patients are going to be transferred to the NICU. That's where they will be recovering. The recovery is typically uneventful. So hospitalization is long, but the patients typically recover from this very well and don't have a lot of complications. So now I can look at page 1072. Like I said, your ventricular septal defect. So very similar. Ventricular septal defect is an abnormal opening in the wall between the right and the left ventricle. So ventricle instead of atria is where the opening is, but the same issue is happening. So this opening allows for a certain amount of oxygenated blood from the left ventricle to be shunted through the defect to the right ventricle. So as I said, same thing's happening. The oxygenated and deoxygenated blood isn't separated as it should be because of this defect. So there we have a mixing of the blood. If you keep reading, this one has a little more specifics on it. The inefficient shunting of the oxygenated blood displaces the blood that needs oxygenation. So that means there's blood that needs oxygenation for the body and it's not getting it. And so the blood is still flowing throughout the body even though it's not oxygenated. This results in enlargement of the heart. So the heart is trying to work harder and those muscles become enlarged. If you will skip the next paragraph and look at the next one, it starts with a VSD is repaired. So a ventricular septal defect is repaired similar to the ASD with a small Dacron patch sewn over the defect. Primary closure is rare for ventricular septal defect. So you need to know all of that part. So Dacron graft, and it's going to be a very similar repair as the VSD. So I've got some cool pictures on here so you can see what it actually looks like in this surgery. So there's your atrial and ventricular septal defects. Make sure you watch both of those surgeries. Okay, that brings me to closure of patent ductus arteriosus, or PDA. So not talking about the PDA that you shouldn't be doing in public, of course. This is something different. So if you Google it, you might want to spell it out. So these pictures show you where the abnormality is going to appear and how it affects the blood flow of the heart. So the aorta and the pulmonary trunk are going to be separated, and these open ends are going to be sewn back together. So it's exactly what it shows in this picture for you. So you're definitely going to want to read through this surgery in more detail than the others, but I just wanted to point out that picture to start with. Let's look in your book and start at page 1072. It starts with what we're working with. So PDA is failure of the fetal structure to completely close after birth. There is a note that I want you to add in on this one. failure of the closure of the connection between the pulmonary artery and the aorta. So let's be more specific. So it's in here on your picture, but I wanted to add the note in your book. So this is failure of the closure of the connection between your pulmonary artery and the aorta, as you see in this picture. The bullet point right after that, so your first and second bullet point, you should definitely read all the way through. So your ductus arteriosus connects the pulmonary artery to the aorta in order to shunt the oxygenated blood directly into systemic circulation by bypassing the lungs. PDA, patent ductus arteriosus, can coexist with other abnormalities. So it's telling you this so you know when you do this surgery, you probably won't only be doing this surgery. You'll be doing multiple of these cases together. So this is very specialized surgery, so you'd be on a specific team if you're doing this. So not just the heart team, the pediatric heart team. So very specialized, and you will get trained on these things. Okay, you can look at page 1073. And you need to know the positioning for this one, right lateral position. I mean, general anesthesia, hopefully you're noticing that on all of these cases, general anesthesia, and really big prepping and really big draping on all of these. I won't go through the whole surgery, but I want to point out a couple of things to you. So surgical procedure number 1. So in infants, the surgeon's going to make the incision through the 3rd intercostal space, but with children or anybody a little bit older, it's going to be through the 4th intercostal space. So that part does matter. You're still going to be coming across the same muscle after you get it open. So that's serratus anterior muscle. So after they're retracting the lung so that they can get to this and repair it, I want you to look at number 4 in your book. So the aorta, the main pulmonary artery, the vagus, recurrent laryngeal nerves, and the thoracic duct are all identified. None of these can be injured during this surgery. So they want to prevent injury during the surgery, during the whole case. So they're going to be looking for these anatomical structures and avoiding them throughout. So it's kind of like working in a landmine. Like, I can't hit that, but I want to work on this. That's right next to all the landmines. So just keep that in mind. In addition to everything being smaller, you still have all these landmines surrounding you that the surgeon has to look out for. So you truly have to be ready for anything because everything's so close together, mistakes do happen. They could puncture another nearby artery, something like that. So you want to always be ready to do anastomoses and fix repairs. Anything you can have on the field to help stop bleeding, you should have that up there too. Okay, after that part, I'm not going to go through the rest of the surgery. I told you what anatomy they're going to be looking out for. So flip over to page 1074, and I'll actually show you some more pictures. So the picture in your book is pretty good. It shows you how they're going to close this PDA. But I wanted to show you, so what I pictured was your surgical ligation. So they use suture on this one. But there are 3 different methods for closing this PDA, and you need to just be familiar with all of them. Not the details, just know that there are 3 methods and what they are. So one you can see pictured, it's the tie is brought around the ductus and tied around. So they're going to put a clamp and then tie around it. You guys are familiar with that. Your second option is to do a continuous suture. And this is going to be placed at the lumen of each stump. And then your last option are the metal clips. So they could put clips over these like hemoclips that you've seen similar. So they'll put clips on here instead of suturing. So that's your third way of closing it. For this, I want you to look at the procedural consideration. Placement of metal clips avoids having to place the right angle clamp on this thin, friable vessel. So you are doing less harm basically to the patient's body by using these clips because we're not having to clamp off that friable vessel. Placement of metal clips also shortens the procedure. You're not having to clamp, clamp, cut, tie, clamp, clamp, cut, tie. You are just clipping. It's a lot faster. Even if you are dissecting with clips, it's clamp, cut, clamp, cut. So makes it a lot easier. Lastly, the metal clips are going to decrease the amount of time that the left lung has to be retracted. So yes, in general, clips are great because they're going to save money, which equals saving time, which equals better recovery for the patient. But you need to know all of the options that are there and the special procedural consideration for your metal clips. Okay, after that, so we have closed the PDA in one of these three fashions I told you about. After the ligation and division, they're going to leave that pleura open. They're going to do this just so it can drain any air. So they're going to place a drain catheter into that left pleural space for drainage of fluid and air for 24 hours. And that's the end of that one for you. So you can watch that surgery so you can understand what's happening on that one. Okay, that brings me to 1075. So this is repair of coortication, I almost said it wrong, coortication of the aorta. So this presents in pediatric patients, as you can see. The high blood pressure before the point of cortication is one issue, and then the other issue is the low blood pressure beyond the port of the cortication. So you can see in this picture where the coortication usually appears, but it's a major stenosis in the vessel. So the blood isn't flowing through there properly. So that's why we need to go in here and repair this one. So look at your book. Coortication of the aorta is localized narrowing of the aorta in an otherwise normal vessel. So for this, I want you to know the difference for the adults and the children. In the adult, the narrowing is usually distal to the left subclavian. In infants, the aortic cortication, the obstruction is usually proximal to the ductus arteriosus. So one difference that you need to know. Then look at your pre-op diagnosis and procedures. So for neonate, we're going to diagnose this with echocardiogram, and the same thing with adolescents and adults. We're going to be using echocardiogram to diagnose. Now, we still know that heart catheterization and angiography is going to be best in really demonstrating where the narrowing is and where we want to make our repair. Okay, that brings me to pre-op preparation. So know the position for this one's posterior lateral also. And now we can start looking at our practical considerations. So elective surgery is often recommended at 3 to 6 months of age. And that's because if performed earlier, obstruction may reoccur. So they don't want to go in and do the surgery twice. That's putting our patient at too much risk. So we are going to wait until the right time when we know it's not going to reoccur to schedule this surgery. Okay, so make sure you read through all of that, because as I said, I'm not going to go through the surgery step by step, but I will go over the important part, because you guys know the steps by now. It's the same for these surgeries. So it's the same pattern, so I won't just bore you with repeating the same story. So let's look at 1077 at your picture. So this is showing you what the end-to-end anastomosis repair, the main part of the surgery that they're going to do. So you'll see they have to expose the coortication first of all. They make their incision sites on either side of the vessel where it's healthy and it's not stenosed and narrowed. Then they're going to anastomose those free edges, advance that closure all the way around, and then your anastomosis is complete. So know that they are going to use a 5-0 or 6-0 absorbable monofilament for this one. And we know the absorbable monofilament that they usually use. So make sure you are remembering some things that you learned from the suture chapter, the surgical wound, when you're studying this stuff. Okay, so after that, you'll see that's how they're going to do the anastomosis, but I want to point out one more thing, your procedural consideration. They're going to use a Dacron tubular graft to do this one. So hopefully you're noticing a pattern. You're in the same opening, just the details are a little different. But anytime we need to fix these repairs, we typically are either making a hole and doing a graft from something in the body, or we're getting a synthetic graft. So hopefully you are seeing the patterns here. But that is your coortication of the aorta repair. Okay, so that brings me to blue baby syndrome. So hopefully you've learned a lot about this one, because there's a lot more information about it in your book and of course the movie that you might have watched. So look at repair of tetralogy of, everybody says this different. So tetralogy of Fallot is what I was always told. It's definitely Fallot, you don't say the T. That is because I looked it up. So this was a French surgeon, and it was Fallot, not Fallot. And he is the one who basically found this blue baby syndrome. So you can read about that person also and find more information. But I've got a good picture on here so you can understand what's happening in the tetralogy of Fallot, and you can see the flow of blood flow and how it's interrupted with this syndrome. So this is the most common cyanotic heart defect in children, the most common. And then you need to know how many defects there are. So tetra, 4, playing Tetris. So there are 4 defects in here. You need to know that the first 3 defects are congenital, and the 4th is going to be acquired as a result of the increased pressure within that right ventricle. So you'll see with this that people say if their child has this, they are going to squat down when they feel like they are faint or having some sort of hypotic spell. So this usually clamps down on that femoral artery and increases the pressure of the blood. So it kind of forces more blood to flow. So this is kind of the same idea of what I would do when I was scrubbed in. So when I was scrubbed in and my legs started getting tired and restless and I needed to get the blood flowing in my legs, I would just put all the pressure on the heel of my foot and push on it. So it would kind of occlude that femoral artery for a moment. And then when I let off my heel, whoosh, the blood would rush through my legs. So I know it's helping rush that blood through as I want it to do. So kind of the same idea with these people that are having hypotic spells, usually after exercise or something like that. So they feel faint, like they're gonna pass out. So they squat down to try to deal with that. So as I said, tetralogy of Fallot results in cyanosis. So that's why they call it blue baby syndrome, because these babies are going to appear blue. Episodes of several cyanosis with rapid breathing may even lose consciousness. So this is a very involved defect. Well, there's 4 defects that need to be fixed. So let's look at page 1079, top of the page. Infants with severe tetralogy of Fallot may require a shunt between the aorta and the subclavian artery and the pulmonary artery. This is going to increase the blood flow to the lungs. The shunt allows for more blood flow to the lungs for increased oxygen saturation. That's what these patients need, right? We need increased oxygen saturation. Look at your instrument, equipment, and supplies. You'll see you need 3 different patches. So as I said, you're going to be doing 3 repairs, and your 4th is acquired from this situation that the patient has. So we are going to have 3 patches, not 4. Okay. So I'm not going to go through this surgery because I've got the videos on here for you. So I've got one there, but then I've got one at the end here. So tetralogy of Fallot, this image will show you what the blood flow is like, where the blood is being mixed, where it's purple, where it shouldn't be mixed, and then where it's oxygen rich and oxygen poor. So hopefully this picture will help you better understand what is happening with the blood flow and why these babies appear cyanotic, because they have oxygen poor blood where there should be oxygen rich blood, and we're unfortunately having the mixing of blood. So these pictures that I've added, this is a little morbid, but these are babies that have had this repair and then passed away due to other reasons or maybe reoccurrence, and because of that they studied their patches so that we can get better in the future. So these pictures show really well exactly where the patches are, but yes, these are cadaver pictures of babies that had this repair. So either something else happened to the baby, they had some other comorbidity, or I mean, I really couldn't tell you what happened. Maybe the repair didn't take, and an emergency happened and they weren't able to come in and fix it in time. I'm really not sure, but it gives a great picture of the anatomy for you. So if you're having issues with the anatomy and understanding it, take a look at these pictures and you can see exactly where they're going to put those patches. I also thought it was interesting to see what the patches look like afterward, because when you're putting in a brand new patch out of the package, it's this beautiful white thing, and you know it's going to be covered with blood and kind of adhered to the tissue after time, but it's different to actually see a picture of it in a patient that is deceased. So very different. Make sure as you're reading through here, you're looking at the stuff you need to do the case. So as I've always told you, the things you should pay attention to: what instruments do I need for this case? What supplies that are special? And what equipment do I need in the room? Because remember, your nurse isn't always going to be there to get the room ready for you. There are times where you're going to have to do circulator duties. Hopefully you can see that in heart surgery, we need a lot of different things in the room. So it's not anything like general surgery. It's very specialized. So I hope you're paying attention to all these details as you're going through it. And if you have any questions, feel free to ask me. And if you have specific surgery questions and you want the real life story, you can of course ask Emily Conrad, our surgical site coordinator. She will be on Thursday to share another video with you. It will be after your exam, but this is just to give you some more overall education on cardiac surgery. So it's not necessarily to prepare you for your exam, but to help you understand more about heart surgery because it is so complicated. So I hope you enjoyed it, and I hope you guys have a great rest of your day. Talk to you soon, guys.